Our last presenter is Mr. Nongyai, and is well experienced. He has 10 years of experience in development sector, especially in health. Presently working with RRC Northeast, Guwahati in Assam, and previously worked with organizations like NHSRC Delhi, Clinton Foundation, Plan International, etc. And involved in various research studies, assessments, evaluation, such as VHSNC, RKS, ASHA program, etc. Mr. Nongyai.
A very good afternoon to all. In fact, it was a really impressive presentation from Dr. Kano. Though I have most of my presentation would be highlighting most part on actually, in fact, most on the area of concerns, rather than impressive data, because this is one of the gray area where we have conducted this study, the Village Health, Sanitation and Nutrition Committee in the context of northeastern states, where Regional Resource Center has conducted an assessment of in the three states, namely Manipur, Meghalaya and Tripura, and we are looking forward to conduct the similar study in the rest of the 8 states too in the near future. As we all know, as most of us knows about Village Health, Sanitation and Nutrition Committee, as it is one of the components under community process in National Rural Health Mission of the country that actually attempts to bring about community involvement, participation in the health programs. However, various experiences based on our field visits, plus the various visits like common review mission visits and all, it has talked about Village Health and Sanitation Committee, though it has been constituted, but its functionality is still questionable in many parts of the country, especially in the context of northeastern states. So with this background, RRCNE conducted this study in 2011-12, particularly during the March to July 2011. We selected 3 districts, each from Manipur and Meghalaya, and 2 districts from Tripura were selected based on its geographical representation. And of the identified districts, we have selected 10% of the VHSNCs, and the members of VHSNCs, especially the member secretary or the president, were interacted through open and semi-structured interview schedule, whereas other members, we had discussion with them, and also we had discussion with the community, and side by side we had interaction with the program managers at different levels. So directly going to the findings without taking much time, as far as the basis of formation of Village Health, Sanitation, Nutrition Committee is concerned, in 2 states we found that the norms of Government of India guideline of constitution of VHSNC based on the revenue villages has been followed in Tripura and Meghalaya. However, this guideline has been totally diluted in the state of Manipur, where they have attempted to constitute the VHSNC either based on the number of asas they have, so that every village having an asa should have a VHSNC, or in one of the districts, they have even followed the number of villages rather than the number of VHSNC. So what has happened as a result of this, the government they have formed number of VHSNC much more than the Government of India approved number in some of the districts, and in one of the district it is little bit more like that. So what actually it has affected the program is that as the approved budget from Government of India comes based on the number which has been approved by the government. So in the field many times, especially in the Imphal West district of Manipur, they have actually distributed the amount among those number of VHSNC form, so they do not end up receiving the actual amount which they are entitled for. And in case of Chandel district, only 60% has received the fund, and the rest of the 40% is non-functional because they haven't received the fund because of the fact that they have formed more number of VHSNC, diluting the guideline. Findings from the data of Meghalaya shows that around 27% of VHSNC in Jaintia Hills and South Garo Hills receive rupees 20,000 and Tide 20,000, 10 and 11. But we tried to understand a little bit further why it is so. But it was not that the government of India has released 20,000 rupees, but the state actually in 2008-9, they haven't released 10,000 to the untied fund to this particular VHSNC, and they have released it in the next year. So we can assume that they were also non-functional during those period of time because of non-availability of fund. In Manipur, one good finding is that 11.42% of VHSNC, especially in the Valley district, were engaged in fund generation activities ranging from 3,000 rupees to 8,000 rupees. So it was one of the good findings among the other areas of concern which we have come across. Utilization of fund was found to be good in most of the VHSNC where we have tried to understand the previous year of these things, fund utilization. However, one thing which we have noticed, especially in the state of Manipur and Meghalaya, is that the one-time withdrawal of the entire amount. Once they receive the check of 10,000, it is deposited. Once it is credited, they just withdraw it. The reason was also quite justifiable for some of the VHSNC because it takes lots of time plus amount on traveling from the village where they belong to, especially in an accessible area, to the place where the bank is located. And as far as utilization of fund is concerned, mostly construction, community toilet, purchasing of furniture, and some cleanly activity. And though they have claimed that VHND has been organized regularly, however, there were serious concerns related to VHND, especially in the context of Manipur. The participation of VHNC members other than ASA and Anganwadi workers were very poor across all the states. And as far as participation of ANM, especially in Manipur, in the VHND is concerned, it was found to be very poor. So the service delivery system, the service delivery during the time of VHND is really questionable because unless and until ANM is there during the time of VHND, from ASA or Anganwadi worker, at the most we can expect some, like health talks or some kind of counseling, but not the actual service delivery. Participation of, in fact, ICDS officers and all, and MPW, LHV, or PH department people was so poor, even though we always said that VHND should be, or VHSNC platform in the VHND, this should be considered as a platform for intersectoral coordination at ground level or field level, but in practice it was not found to be happening. Monthly meeting was irregular and it was more on need-based, but not a kind of a regular monthly meeting. Though we also observe good practices like wall painting and hoardings in Meghalaya and Tripura, we are covering various health messages, and as earlier mentioned, community level donation drive in the state of Manipur. The supportive supervision of VHSNC activity by either ASA Resource Center or this existing structure is found to be almost absent in Tripura and Manipur, and it was very limited in Meghalaya. Like it was more of like checking the records or getting the data. But the importance of using those data, which is all the records maintained by the VHSNC as a platform or a kind of basis for having a dialogue with the community, was never realized. So some of the recommendations that we have is that there were conflict where in some places there are more than one ASA, like in Tripura, but they have one VHSNC, so there were conflict like who will become the member secretary. So obviously it has to be decided by the VHSNC themselves, but what we would recommend is that they can go for a kind of a, 6 months by one ASA, then another 6 months, something like that they can go for that kind of arrangement. And intersectoral coordination really need to be strengthened further. And reorientation of VHSNC. And what we have come across is that, yes, reorientation happens, but in most places it is merged with the ASA training. What advantage they have taken is that in most places, as ASA being the member of the VHSNC, during the time of regular ASA modular training, they took up a couple of topics of VHSNC and they are being taught there. With an expectation that ASA will go back to the village and she will again do the reorientation of all those VHSNC, but not with an effort from the system to have a follow-up of that, whether it has been really done or not, and what are the helping hand that is required from the system that was totally missing. As far as PRI involvement is concerned, it was quite poor, very much limited to signing of checks or some financial matters. So support structure for community process activities or ASA Resource Center, like these are smaller states in Northeast where we have already constituted ASA Resource Center. So actually what they can do is that they can actually bring in this component of VHSNC under that umbrella of ASA Resource Center. We have ASA facilitators in those states. They have divisional ASA coordinator, district ASA coordinator, lots of people working in the state. So, but the thing is that they were independently working only for the ASA program. So ASA being a member of VHSNC and VHSNC and this ASA program together under community process, this could be looked after by this particular already existing resource center. So therefore, like what we finally recommend is that all the states can really strengthen already existing ASA resource center as a kind of a cell for the entire community process program. Thank you.
Thank you. Thank you very much, Mr. Nongyai.